radioactive particles. And usually that would occur within 2 to 5 weeks after randomization. Interestingly, they did say that there was some evidence which suggested, that the pulmonary fraction percentage wasn't the main thing to be concerned about. So initially they were not including patients that were getting 20% of the pulmonary shunt, but rather the data showed that it was the overall dose. So they altered it so that anyone who was receiving 25 grays or more to the lungs was excluded, or at least not given this option, or if deposition into the gastrointestinal tract or vascularity of that couldn't be avoided. So in terms of the distribution, so they started off with 496 patients. After exclusion, they had 467 to randomize, 8 of which withdrew consent, leaving intention to treat populations for each group. So 237 for SIRT and 222 for the sorafenib. Further exclusion, so either worsening disease, early death, or other medical causes or decisions would result in the safety population, which we'll describe in a bit more detail. And then finally, after further exclusions and separation of whether they received the intended treatment or not, we're left with the per protocol population. So from this diagram, it's worth noting that this safety population group from the SIRT group actually doesn't say SIRT treatment, it says the workup of it, which we'll come on to a bit later. And also 26 of the patients, although from the SIRT allocation group, ended up receiving sorafenib instead of SIRT. So just to recap, intention to treat. So this is assessment of people based on their allocation of group rather than whether they dropped out or if there was any changes to treatment, etc. Safety population. So this is the group whereby the number of patients was used to assess for adverse effects. And these were patients that received at least 1 dose of sorafenib, or as we were saying before, at least the workup, so the angiogram for SIRTs rather than yttrium itself. And then the bottom group we discussed before, so per protocol analysis is actually looking at the patients that received the intended treatment protocol. So whether they stuck with the sorafenib throughout and the SIRT through the treatment plan as well. So in terms of the outcomes that they aimed for, so the primary outcome was overall survival, and this was based on time from the date of randomization up to either death by any cause, or if they were still alive, the last date that they were followed up. And then a multitude of secondary factors that they looked at, so including the response to tumors, the time duration where they were progression-free, safety, i.e. adverse effects or toxicity, and also quality of life. This chart here is just to demonstrate that from the comparison of SIRT and sorafenib group, almost all of the percentages between the subdivisions were more or less the same throughout. So a very comparable group and good randomization between the two groups. In terms of analysis, so they looked, as we've been saying before, at safety, so adverse effects and toxicity from the treatments, quality of life based on a multitude of surveys, and also CT based on RECIST criteria, all of which were carried out from the baseline, so as close to randomization as possible, 1 month, and then 3 months there onwards for at least a year or until death. So here we've got a diagram which shows the overall survival, and the red line being SIRT and blue line sorafenib. There's no real notable difference as an eyeball, but certainly by figures, they're more or less comparable. So in terms of the mortality, so 83% mortality from the SIRT, or at least deaths within the SIRT group, and 80% in the sorafenib group. The 1-year survival, again, very comparable. And the mean survival was more or less the same as well. So 8 versus 9.9 months in the intention to treat, and slightly interesting use of data, I suppose. They've gone for per protocol population, which showed it was exactly the same between the two groups. Here we're looking at progression-free survival. Again, very similar curves on the graph, and more specifics within the numbers. We've got the same progression-free, or number of patients who had progression-free intervals, and the duration of which was more or less the same. Here we've got some more graphs looking at progression of any disease at any site on the left side. Again, more or less the same. But interestingly, on the right side rather, we've got progression in the liver as a first event. And there's a little pointer here, just pointing out that the SIRT group is actually a lower incidence overall. This is just reiterating the same. Here we've got comparisons of the disease, response to the treatments, and a bit difficult to tell based on those numbers, but cumulatively, complete and partial response was better in the SIRT group. So 19% had complete or partial response versus the 12 from the sorafenib group. And then moving on, we've got 104 patients had disease progression, but what's interesting is that the SIRT group had more progression outside of the liver alone, whereas comparatively, they were more or less the same with disease progression within the liver, or both in and out of the liver itself. This is a graph just showing, or chart showing the side effect profile. And this was actually analyzed by a group external to those conducting the study itself. And there's a lot of numbers on this page, but overall, the serious or any form of adverse effect, either serious, other, or what they called grade 3 adverse effects, were significantly lower compared to the sorafenib group. And there's just a list down here which indicates what was considered a grade 3 or more adverse event. And in terms of the treatment-related adverse effects, the mean number of adverse effects experienced by each patient averaged less in the SIRT group compared to sorafenib, which is not overly surprising given that sorafenib is a systemic treatment as opposed to the targeted treatment with SIRT. And on this diagram, we've got global health status based on the questionnaires. And the red line again is SIRT versus the sorafenib. And overall, you can see that there's a slight decrease on the eyeballing the charts of sorafenib over time. But certainly when they looked into the statistics of it, it showed a significant better result with the SIRT group, both in the intention to treat and per protocol populations. So in terms of what we can glean from that, so there's no real difference of the overall survival, but the tumor response and quality of life was significantly better in the SIRT group. Of note, though, the SARA trial did include intermediate stage HCC as opposed to some other trials or studies where they only included advanced HCC. And at baseline, the SARA trial excluded any extrahepatic involvement purely because the SARA trial was more interested in looking at systemic versus liver-targeted treatments. And most of the patients in this trial had vascular extension, which is known to carry a worse prognosis compared to extrahepatic involvement. Progression-free survival didn't show any significant difference. It might be because the underlying improvement is being masked by the background liver parenchyma, which most of these patients had severe chronic liver disease anyway. And SIRT has got a much better progression rate compared to sorafenib at a intrahepatic level, but clearly there's a higher extrahepatic progression rate as we saw before. Again, probably because it's much more targeted specifically within the liver rather than a systemic treatment option. And we're basically saying the same at the bottom there. In terms of tumor response, so it was significantly higher in the SIRT group. And it is possible that the radiotherapy particles could be hiding tumor response or even tumor progression. But the CT, they felt it was robust enough to use a CT close to the radiotherapy treatment to be able to detect that. But they did mention that there was potential for paradoxical increase in tumor size, which could be misinterpreted as progression rather than tumor response. But they were comfortable. They had radiologists with sufficient expertise, particularly within the liver itself. Overall, SIRT's tolerability was much better, so the side effect profile was much better. And quality of life, as we showed before, was significantly better in the SIRT group. What I did mention was that they didn't look at the cost effectiveness of both treatments, albeit both of them were acknowledged as being very expensive. And it would probably be useful to look at the specifics of the cost effectiveness, particularly as the SIRT group would have had at least 2 day case/admissions based on the angiography as well as the treatment itself. And it'll be interesting to know what the cost was of the associated complications, albeit there's more complications within the sorafenib group. So study limitations. So they accepted that some of the SIRT group did not receive the originally assigned treatment, although they didn't explain in full detail why that necessarily was. SIRTs can take a number of days to be worked up, so we've already said that there can be a delay of up to 2 to 5 weeks from randomization, as opposed to sorafenib, which would be the week following. And as we've been saying, the time from randomization can be a lot longer. Many centers had very little experience with SIRT, but within the criteria to be included within the study, the trial needed certain centers to have at least 10 patients of administration of SIRT, as well as certification to be included within the trial. And they didn't evaluate the actual dose-related efficacy of SIRT itself. So in conclusion, so there's no significant difference overall between the survival of the 2 groups. Quality of life was much better compared to sorafenib, which might sway or help within the decision-making of which treatment option to go for. And SIRT had a much better local efficacy, and it may have a better, more appropriate role within treating less advanced HCCs, so particularly the intermediate ones, based on the current studies. Thanks very much. Any questions or discussion points?
Thanks, John. I think that was a really good summary of the SARA trial in the paper, so thanks for that. If any of our participants do have any questions, please pop them in the chat box below, and we can put those to the panel. So I guess one of the things I wanted to talk about is sort of the role of SIRT in treatment for HCC and perhaps how it differs in the UK versus the US. So perhaps if we could go to Dr. Najran from the Christie for a UK perspective.
So recently this has gone through a process where NICE have approved the use of SIRT in HCC with specific criteria. So it initially, colorectal metastasis to liver have also recently gone through that same process, but with relatively strict criteria, meaning only a certain number of expert centers were allowed to deliver such treatment. And HCC has also gone through the same process. And again, it is available on the NHS, again, through specific criteria and through specific centres. There is a private route as well, where patients can receive SIRT, but for a much wider criteria.
Professor Lewandowski, how does that differ in the US?
Sure. So, radioembolization has been used over the last 20 years in the United States. Its use has expanded quite dramatically, both in the types of cancers that are treated and the number of centers that are offering radioembolization. In the United States, the FDA has approved TheraSphere, glass microsphere radioembolization for hepatocellular carcinoma. Previously, it was under a humanitarian device exemption. So more recently, it was approved, interestingly, for more segmental treatments rather than lobar like we're talking here. For us, for colorectal cancer, SIRT is approved under our pre-market approval for colorectal cancer. The approval indicates using a hepatic artery infusion pump and FUDR, but I think most probably do it off label here. That's not that applied. But again, we use radioembolization across the spectrum in hepatocellular carcinoma. I think 10 years ago, the patient population studied in SIRA was what many of us in the United States saw, those intermediate advanced or early advanced patients. But if you probably looked at most centers in the United States, we're treating more early stage HCC than we are advanced stage HCC. And a couple of reasons for that. One, this paper was published, I believe, in 2017. It was just before the explosion of systemic therapies for advanced hepatocellular carcinoma. So sorafenib is really not the gold standard anymore, and there are a lot of options. So finding the role for radioembolization is an interesting discussion in these advanced patients these days. But given the segmental dose with long time to progressions, high rates of complete pathologic necrosis, utilizing this as a bridge to liver transplant, downstaging to liver transplant, definitive therapies for those patients that tumors are outside of what we consider for ablation or resection, we really moved radioembolization earlier in the treatment paradigm. So it's really changed here in the United States. While we still consider it for patients with locally advanced disease, we really think about it segmentally for HCC.
That's really, and in terms of how you would treat that, because I've not really heard too much about segmentectomy. I think it's not something that we really do very much in the UK. So how do you go about doing that?
Well, I mean, so there have been several studies now, mostly retrospective, but now at several different centers, one being here at Northwestern in Chicago, another center, University of Washington in Seattle, and then Mount Sinai in New York, as well as a group down in Florida, University of Florida, and the main contributor moved to Jacksonville Mayo Clinic, have published several papers on the concept of radiation segmentectomy. And really the idea of, we look at time to tumor progressions, when we think about chemoembolization or bland embolization, it tends to be 3 to 6 months. With segmental radioembolization, it tends to be 2 or 3 years. And most of the time, in many of these studies at 5 years, the treated tumor has not progressed. It's development of new tumors that causes the progression metric to be met. And reaching segmental doses, and the published literature currently is heavy on the glass microspheres, and people are using resin microspheres. And I think there are some clinical trials now in terms of how to optimize the dosimetry. But based on radiology pathology studies, if you give based on MERD dosimetry, which assumes a homogeneous distribution within a segment, up to 2 segments, if you give over 190 gray, there's about an 85% chance of getting complete pathologic necrosis at explant. So not radiologic outcomes, but actual tissue outcomes. And more recently, new data suggested if we would get over 400 gray, we have all of the tumors have complete pathologic necrosis. Now, these are retrospective studies. They're still small centers. I mean, small series, single center, but it is triangulating this as potentially a definitive therapy. And it's important. We think about bridging and downstaging to liver transplant, but also there is some evidence now to suggest if you have complete pathologic necrosis at transplant, on the explant, those patients have longer time to recurrence, longer progression-free survivals, et cetera. So I think that the concept of having complete necrosis as your bridging therapy is an important one, and I think we'll be doing more and more of this as patients are waiting for liver transplant.
Yeah, thank you. Another question that we have, sort of this obviously being aimed at trainees, is about the training for SIRT and use of SIRT. And I know that Dr. Najran's mentioned that it's only allowed to be done in certain centres in the UK. So Dr. Najran or Dr. Bell, do you have any advice or guidance for UK trainees interested in training in this procedure?
I know Winnie's, who's your co-chair, has come to visit me in the Christie, and Dr. Bell as well. I think in terms of training, because you are restricted and COVID's not really helped the situation, the key is to visit these centres if you can, and break down the procedure to its basics. So by the time you're visiting SIRT therapy, you have the basics of angiography, coil embolisation under your belt. And what you need to do is really break it down to the basic principles of what area of the liver you're treating, and how do you go about this safely. Professor Lavandowski's talked about the advanced elements of SIRT, talking about high doses and segmentectomy. We're playing a little bit of catch up there here in the UK. So the traditional method of coiling off the GDA and coiling off the right gastric and staying proximal and treating the entire liver is really the old school way of approaching this. And we are becoming a little bit more focal. And I think really the best way to do it in terms of training is to visit one of these centres if you can. I know COVID's restricting things, and go through both processes. That's both the workup and the treatment process. The indications for SIRT as well will differ your approach. So when we're talking about segmentectomy, HCC, it's going to be a slightly different approach to diffuse colorectal metastasis. So again, seeing different cases will also broaden your teaching as well as to how we approach each case.
So I've got a question from Dr. Hammond. So he asked, what's the evidence would we require in order to abandon this technology? Does Sarah provide this? Apologies to John and Glenn.
I think that's a lovely question from Chris. Just to go back to the training element to this, I'm learning every day, and I think Bob mentioned the data from the legacy study. So we don't stand still in SIRT. So there's just changes all the time, and I'm thinking back to when this paper was published. Everything has changed from that time. The technique, the use of cone beam CT, the dosimetry. So we touched on probably about the BSA being used, how we shifted towards partition, voxel-based dosimetry. When it's segmentectomy, you can do it as a single compartment because you're just blasting the tumor, and we're seeing people push those doses. So from a teaching perspective, I value hugely from my senior colleagues when I started at the Christie, just watching them do cases. We have an MDT to choose patients that we're going to treat, but then we bring those patients back to the MDT after the workup to discuss about the dosimetry, because that is absolutely key. And we just learn from each other's experiences as well. So the treatment has just evolved hugely. In terms of Chris's comments, I remember when the Sarah data was published, and there was that concern after SIRFLOX that this is another negative study. And I think a lot of oncologists turned around and said there's no improvement in overall survival, so that's it, SIRT is dead. But there's so much to learn from this paper. There was a lot to learn from the subgroups about the ALB, about less than 25%, about the post hoc analysis later, looking at 100 grades of tumours, the disease control in the liver, all these things we learned from Sarah. And then the study has moved forward. And we don't see a lot of RCTs in interventional oncology, do we? It's all retrospective pieces of work. So it was ambitious of Certex to do SIRFLOX, Sarah, Cervinib, to commit to these studies. yeah, the overall survival wasn't met, but there was a lot to take from it. And the recent reviews, so Pav talked about, for colorectal, we had commissioning through evaluation, but for HCC, we had this multi-technology appraisal, which looked at the cost effectiveness. I accept that that was against sorafenib, and now we're seeing atezo-bev coming in as a standard of care in the UK. But that MTA process took 3 years, and it showed that it was cost effective, that it had a place. So I attended that meeting. There was about 30 people there making that decision. So it was a very robust decision based on RCTs, but there's also a role for real world data now. And there's definitely an option for SIRT in the patient pathway as we move more towards personalized therapy. So you have to learn from each of these RCTs, the treatment evolves, and there's definite position, but we need to continue to build the evidence. So there's definitely a place for radioembolisation.
Thank you. I think Glenn would also like to make a comment on the cost effectiveness of SIRT as well. Glenn, would you like to elaborate?
Yeah, thanks, Winnie. I think, thank you very much. I think John's already covered it, actually. The cost-effective analysis that was done after SARA and Cervanib was a key part of what drove the NICE decision, and was a cost-effectiveness versus sorafenib, as John's pointed out. So I just wanted to add that, because Jonathan was unsure about whether cost-effectiveness played a part. So it did, and it informed the decision that NICE made. And Chris, I know where you live, all right? I don't, by the way.
Yeah, I want to point out something. I mean, John mentioned this, but Sirtex gets a lot of credit for not just the SARA trial, Cervanib trial, ceramic trial, Surflox. It was unfortunate that they ended up negative, in essence negative, but these were bold ventures, as has been mentioned. Pharmaceutical companies do these all the time. They have a little bit deeper pockets, and they are full of negative trials. I couldn't even count how many negative trials came on after the Sharp in Asia Pacific to give us sorafenib. Just many combinations of systemic therapy, some that we're using now. So we have to learn from these, and it's been pointed out a few times, but the patient selection, we as an interventional radiologist, man, we're excited about the technical aspects and the procedures, and you throw in dosimetry, it adds some complexity, but the patient selection is very important. And you look, 45% in SARA had chemoembolization. Well, does that impact our ability to deliver Y90? Probably, right? 34% had main vascular invasion. Those are patients we tend not to offer radioembolization in. At least these days we don't. So these are bad patients. These are bad patients in this particular trial. Now, again, not nitpicking, because it's easier to look back at it and say, well, those are bad patients. It's really hard to recruit and enroll patients. So it's a give and take when you're developing. If you make your criteria so strict, you can't recruit patients. But if you look at, say, the studies for systemic therapies, they do not have a lot of granularity. And oftentimes those patients are very healthy. They don't give you mean tumor size. They don't do a lot of different things. So again, I think that there are potentially some challenges with this. And I want to repeat something, because I think it might have been John again that brought this up, but there was a subset analysis from the SARA study members, and it was published, I believe, in Radiology last year, where they looked at patients that received over 100 gray. It was based on SPECT CT. So now we're talking about partition modeling, retrospective, but based on our planning day. And patients that had over 100 gray had better tumor control and better survival. So now we're seeing that dosimetry does make a difference in these patients, right? And that was followed up by a more recent study published in Lancet, I think GastroHep in 2021 from Etienne Garin. And this was with glass microspheres, but this was called the DosiSphere trial. I think it's very important. I mean, if you look at it, there's a lot of granularity. Mean tumor size over 10 centimeters, 2/3 had vascular invasion. These are advanced patients. These are big tumors. And they randomized not versus chemotherapy. It was glass microspheres versus glass microspheres, but they used a standard dosimetry versus a personalized dosimetry using SPECT MAA, delivering over, I think it was 205 gray. And he changed the response rates from 22% with standard dosimetry to 77% with personalized dosimetry. survival went from 11 months to 27 months. And then really interestingly, in this really these heavily bad disease patients, the secondary surgery rate, so patients converted to surgery, was 35% in that personalized dosimetry arm. So again, thinking about when this study was developed, our knowledge of dosimetry was different. I think if we were to redo this study, our patient selection would be different and our dosimetry would be different, right? And maybe we'd have a different outcome. But the unfortunate thing is now we're not looking at sorafenib, and now versus as Atezo-Bev or something else, it's a moving target. And the reality is, I think most people now in this space think it's not one versus the other, it's some type of combination, right? How do we combine these therapies together?
Thank you. I think, yeah, I've heard about some places doing SIRT just before resection as well. And but we yet to see more published evidence about combined treatment. I just want to ask the panel, what's your view about using SIRT as a bridging treatment? What do you think? Do you think it actually increased the resectability or increased the chance of transplantation? And subsequently, do you think we have enough evidence to say that a patient who managed to go on to have resection or transplant today, does that improve their survival?
We heard before that it does, and it comes from very much the American perspective, because we're starting on the right hand side of the BCLC and moving across to the left, and they are so strong on the left hand side and have so much experience there. So the US perspective we're learning from all the time, but it's that time to secondary treatment. It's massively more cost effective than TACE, because one SIRT will hold people for a longer period of time. There's also downstaging to transplant as well. There's downstaging to resection. So that was called a curative intent sort of strategy. The role for SIRT is massive, and we're quite inexperienced at that from a UK perspective, because we've been treating colorectal for years and it's a different area for us. So be interesting to hear what Prof. Lewandowski said, before about that and his view.
Yeah, some interesting observations in few of the centers showing after SIRT there is a contralateral fee. So in some centers, I think they've started using this as a replacement or a conjunction for a portal vein embolization before cholangiocarcinoma resection. SIRT also does that. So that is one point which maybe in the future can give us some more options in terms of treatment.
Yeah, sorry, go ahead, Glenn. Oh no, go ahead. I'll go after you. That's fine.
Thank you. I just wanted to add to what John's saying, and as most of you probably know, the Newcastle group have got some very promising early data with both resections and bridging to surgery, and indeed with a small number of patients going on to a transplant list and staying on the transplant list safely and longer and things like that. So whilst the data is limited compared to the data that Professor Lewandowski can provide, the signs are certainly very promising, as it does actually obviously treat the disease in the liver whilst you're waiting, rather than just holding the patient.
Yeah, I was going to come back to, I mentioned earlier that most of my patients that I treat with hepatocellular carcinoma now are early stage. And, now the rules here are that patients that are within Milan criteria have to wait 6 months before they get their MELD upgrade exception points. So we bridge almost everybody. And at our institution, we used to bridge with chemoembolization, but we've converted to radioembolization because of both the longer time to tumor progression and the high rates of pathologic necrosis at explant, which we think is going to give a better outcome overall. Although much more work has to be done with that. We also use it in downsizing, and you can use a lot of different things. And at our region, when we first started doing this, it was based on the size, resist, not M-resist. So if you're just basing it on necrosis, you can jump right at it with TACE or bland embolization, but we found a higher rate of downsizing based on size with Y90 versus chemoembolization. People use ablation for bridging, and that's a very reasonable thing to do, but there is a risk of tract seeding. It might be small, but there is a risk, and we've seen it occasionally, such that we don't have to bridge somebody putting a needle into these tumors. We don't biopsy many of these because of the risk. And I know you can ablate the tract and things, but we can give an ablative dose through the arteries for that. So bridging and downstaging makes a lot of sense for us in those regards. And then something that's been alluded to is the idea is what's been termed radiation lobectomy. But the idea is if somebody's a surgical resection candidate, but their future liver remnant, the amount of the liver that would be left behind after surgery is not large enough to sustain metabolic function of the liver, there are methods to increase that FLR. And I know portal vein embolization is something that's been reported, and it's a really fun procedure for us interventional radiologists, and there's a lot of debate as to what the best way is. It with liquid embolics, which most people are sort of going towards now? Is it particles and coils, et cetera? I think the evidence for portal vein embolization is better or more robust. There's more of it in patients with, say, metastatic colorectal cancer. There is some controversy of portal vein embolization in the cirrhotic HCC world, in the hepatology world. These patients may have some underlying portal hypertension, thrombose. It could propagate if that cirrhosis gets worse, and now you have main portal vein invasion. If they don't undergo resection, if you want to do chemoembolization, now you've embolized the portal vein. So there are things that make sense. The other thing is with HCC, I think we're all very comfortable with the biologic test of time, right? We watch these tumors till they get to a certain size, they get put on a list, they have to wait 6 months. So we're comfortable with this biologic test of time, more so than we are with, say, metastatic colorectal cancer. So I bring that up because the hypertrophy after portal vein embolization is likely more rapid than it is after radioembolization, but you have the benefit of treating the tumor at the same time. So it is something of great interest here in the United States. A lot of us are studying this. We are using it. We do it from our tumor board. There are growing publications and projects on this as a means to facilitate resection. So again, early stage, a lot of applications for radioembolization.
Thank you.
I think that sort of leads nicely on to we wanted to talk about the future of SIRT research. So I guess that's kind of you've already touched on some of the things there. In terms of in the UK, what are the next steps for us?
So I'd recommend people looking at the 5-year NICE strategy. So there's a shift now towards real-world data. So we heard about legacy study before, I think being one of the first studies retrospective that the FDA have looked at and approved the device. For us, so the boundaries are sort of changing. That includes for NICE as well. So there's a need for RCTs, but there's a need for registries as well, and just more. I sit on the NICE Interventional Procedures Advisory Committee, where we look at safety and efficacy, and it often doesn't lead to commissioning and reimbursement. So there's a disconnect sometimes between the evidence, and it can be frustrating seeing that build over time. You know, drugs coming on board, the shifting environment in which we work, and it seems to take a long time to get our hands on innovative medical devices. I wouldn't say SIRT's been around for a long time. When I sat through these processes, I could picture patients who'd been downstage to resection and cured, whereas the people in the room could just look at the evidence put in front of them, and it was challenging at times, but the right verdict was reached in the end. So I think there's definitely going to be changes now with more real-world data coming into play and helping drive decisions, and there will be a registry in the UK to collect all of the data now. That may be part of the Hunter registry, which is a broader HCC registry which collects a lot more information, but we're trying to add some pages to that for the dosimetry for combination therapies with immunotherapy as well. So yes, there needs to be studies in immunotherapy and everything, but some real world data as well. And hopefully, as a community, we can be better with dosimetry, patient selection, and driving the therapy forward with studies such as DosiSphere that I think actually portray us in a positive light. And maybe we need to be more focused on patient selection and not too general, and have more targeted studies.
So Glenn, you've got a, thank you, Dr. Bell. Glenn, you've got a question for Professor Lewandowski. So you asked, is there evidence to suggest the contralateral hypertrophy achieved with RE produce more efficient liver tissue than portal vein? Sorry, this is going back to the portal vein embolization.
Glenn, what do you mean by efficient?
I think I saw some data that said that whilst with portal vein embolization or hepatic vein embolization, you get a rapid liver growth, the quality of the liver that grows isn't actually, I don't know how to phrase it, forgive me, doesn't actually do the job as well as if it grows more naturally and slower.
This is true for ALPS, isn't it? But I don't know, I've not seen anything between PV and radioembolization, but with ALPS, it's definitely the quality of liver isn't there. Is it that, you know, you get that rapid regeneration, but the function is affected? I'm not sure about PV and radioembolization.
Oh, I thought it was, I didn't realize it was peculiar to ALPS. Thanks, John.
Yeah, I mean, I think it's a little bit immature. I haven't seen it in terms of comparing PVE versus radiation lobectomy. It's an interesting question. Again, I think that when you treat the tumor, that biologic test of time is good. Even in, you know, I hate to say it, but in colon cancer, it is too. If you're rushing to get to the OR, it's probably not the right thing for patients. You know, how many times have we seen resections and then within 6 months, or ablations for colon cancer, within 6 months, they've recurred. It's pretty common, but that's likely to be a good source. I think there's a lot of interest in actually even studying PVE versus radiation lobectomy. I worry that no center is going to have a large enough volume. It's going to be a difficult thing to do. And there's a lot of, we talked about heterogeneity and how people do things. I mean, there's no consensus on how to do portal vein embolization and yet how to do radiation lobectomy. So I think those are challenging to do, but I think that there's a lot of interest in it. The good news is the interest comes from our surgical oncology and transplant surgeons, hepatobiliary surgeons, which is good that they're interested in the things that we can do. And that's great, because what we do is getting these patients to surgery that otherwise couldn't get there.
And the other thing to throw in the mix is PV and hepatic venous deprivation now as well, which Boris Gier and Alban Denise have been pushing. So yeah, it's almost too many options.
Thank you very much. I just want to thank John for telling us about the plan for UK, and we touch on training side of things just now. Pav mentioned that I've been coming to Christie thanks to John and Pav, that's who let me come and observe some SIRT. But I just want to say that it is very limited training opportunity in the UK because there are very limited numbers of centers doing SIRT at the moment. So we've got some trainee audience who may be interested in arranged training. So I think now the training opportunity is mainly based on maybe an IO fellowship. And if you can arrange any out of program training, that would be the main opportunity. But the deanery training is very limited depending on where you are and which center is available to you at your deanery. So I don't know if the panel has got more suggestion on how trainee can maximize their training opportunity.
I think that's for the UK, that is the key really. So I was a fellow at the Christie, and that's where I learned the principles of SIRT and carried on as a consultant. And you're right, it is very limited at the moment. And again, COVID's made it even more limited. there are two main methods really. Is number one, if you're lucky enough to be within a deanery that does have a centre, which most deaneries should do in the UK, arrange with your local site to visit regularly to learn the basics of SIRT. And the second method is to apply for IO fellowships, and we have one at the Christie. And again, it's as everyone on the panel have said, it's a moving target at the moment. So things are going to change quite significantly. So when I learned to do SIRT, I learned with John and Dr. Lawrence and Dr. Mullen. And again, the basics were to treat the entire liver. We were quite modest on the dosing. And now, particularly John's been pushing higher doses, and the evidence is there to, and Professor Lewandowski's also talked about how we get good responses with higher doses. So the key really is if you can get as much experience as possible by those two methods. So visiting centres that deliver SIRT, but also look at IO fellowships as well. It is a relatively complex topic, and I think if you are looking to develop your overall practice in IO, then an IO fellowship is really essential.
Yeah, as Dr. Najran said, the centers which do limited SIRT opportunities, I think being a fellow is a great opportunity to learn, because you'll be more spending your more time concentratingly into the procedures. I think with the nice accepting more indication, probably the numbers will also gradually increase, and gradually the centers also will start these services. So probably in the future, near future, more centers will be offering the service and more chance of getting to the way.
Can I ask Winnie, so in what context did you organise your sessions at the Christie? Was that as an out of programme, or how did you go about doing it?
No, it's completely, because I'm at the end of my training, and I have been doing HPV MDT, and I felt that it's a kind of a gap that I haven't seen any SIRT because of multiple issues. Birmingham hasn't been able to list any SIRT during my time, and partly because of COVID. Hence, I tried to reach out to other centres, and lucky enough that Dr. Bowers let me come and visit. So, yeah.
Yeah, it's a bit unfortunate, Vinny, because during my fellowship in QE, I had enough number of cases with Dr. Merzad to do the cases. In spite of that rectal things, at least I've done with him 7-8 cases in those 1.5 years. Because of COVID, unfortunate, I couldn't have one cases during that time.
I think it's a difficult time. It has been a difficult period because all palliative treatments were stopped in the NHS. So it was only treatments with a curative intent were allowed to continue. PAV sat on our clinical advisory group for COVID, so was able to keep SIRT going and actually changed it to a day case. So we said we didn't need as many hospital admissions, and so we could keep the service running. But a lot of places, their service stopped. And now when we've had a positive NICE MTA decision, some trusts are dragging their feet in starting radioembolisation because they have a huge backlog of cases to catch up with. So I would say, you know, we're a close network. We know all the 10 centres that offer radioembolisation. It's a small community, and just as you did when you just reach out, when it comes to out of program experience and things like that, you're not supposed to take it in your final year of training. It depends how good and understanding your postgraduate deans are, but they should be, and you don't really need to tell them. You can just, if you agree with your consultant there that you can have it come over and get experience at a neighbouring trust or organisation, they should be very willing for you to do that, and we're happy to take people at the Christie.
I think the other thing as well is the other thing to mention is that COVID eventually will hopefully allow us to interact again, and we've been working quite closely with Certex to develop some form of virtual setting where we can teach the basics of SIRT, but we hope one day we can have in-house courses again, which we have done in the past. which is an excellent opportunity for both trainees as well as consultants who want to gain a little bit more experience in SIRT.
That would be very useful.
Yes. Lovely.
I think the other thing as well, sorry to interrupt, is the MDT. So I know John and Professor Babadowski mentioned tumor boards and MDTs. They are essential to the process of SIRT. It's the actual process of performing a SIRT therapy is relatively similar to other embolic therapies. There are principles behind dosing, of course, but I think if you can attend or gain some experience in the tumor board and the MDT process in how you select SIRT, that is as essential as the process itself.
I just got a final question from one of the audience. Any advice for consultant wishing to gain experience in SIRT?
Is that from Chris?
No, it's for Michael.
Yeah, so for consultants, so we're seeing now with a nice decision that the easy thing is for the 10 centres that were commissioned before will continue. We're expecting other centres to come online in year 2 and year 3 as the numbers grow. Trying to build a service is not just about the IR, it's radiopharmacy, it's nuclear med. So it's a whole training program. I think Glyn has mentioned here that Certex Boston and Truma will have training programs, which often involve traveling. So I'm sure they've adapted and come up with different methods, but often these are driven by the companies to support your training needs. But it won't just be the IR, it'll be a whole group. So you need to take everybody with you. You can't do this service unless you have the support of a whole team of people. I don't think it's complex until I see another centre try and start it, because I take for granted the people that we work with and the way that they adapt and are enthusiastic about the therapy. So it's not easy to start a new service because you need to get all that alignment. But if people want to reach out to us, then they're more than welcome to. Glyn, any of the Boston reps, Truma reps will help drive it as well.
Fantastic. Well, thank you. I think we're coming up to time now. So does anyone have any final points that they wanted to make or to add in the panel?
I was just going to bring up, at least here in the United States, the Society of Interventional Radiology has had a Y90 course for many years now. I know it's been 7-10 years. It happens usually January, February, and if you're a member, I think as a trainee, you might be able to get a pretty cheap membership. You could probably get in and try to see. Again, I don't know what the logistics are, but pretty comprehensive program from patient selection, dosimetry, angiography, cover some of the basics of more common cancer types. So that's another way to at least gain some experience. They actually, some of them have actually included the physics of radioembolization as well. So it'll probably happen again in 2022. Again, look for it early in the year, but it's something to consider.
I'll definitely sign up for that.
That's great. Lovely. Well, I think we are just about ready to wrap this session up. So I just wanted to say a huge thank you to all of our panelists for agreeing to come and talk and discuss this with us. Thank you to John for the presentation, and to Winnie and Jim for helping to organise this session. So yeah, please complete the feedback form that we've just posted into the chat. It'd be really useful to get your feedback on these sessions, and you can also suggest anything that you want to discuss in future journal clubs. And we'll look forward to seeing you again next month. So thank you very much, everybody.
Thank you, everyone. Take care.
Thank you.